Yes, sir.
Okay, I'll directly come to the point. I thank the PCSI for giving the opportunity to interact with so many people. And the topic will be complications of stent. So stenting complications will occur in around 3.5 to 19% of the cases, and overall procedure mortality is around 2.3%. It has many complications, maybe transient. The surgical backup generally reduces the chance, and complications may be related to the stent or may be related to the cath, and is often exerted by the stent itself. One of the important complications is early embolization and migration, occurs in around 7.7%, is the most frequent complications. Prevention strategies, of course, choose the appropriate size sheath, which is generally 2 to 3 French more, Aeroflex or Mullins, and avoid bare, without sheath advancement, because most of the time that is the cause when we are not able to retrieve it well, and our embolization and migration is more. Choose of appropriate length, denaturing the balloon, gluing the stent, maybe with a dye, teasing open the studs of the stent to avoid the punctures, wire in the lumen while preparing, that prevents the damage of the lumen and thus appropriate uniform expansion of the balloon. Spend time on positioning the support wire, because most of the time the support wire would move and then our stent embolizes, and increasing trackability. Maybe a soft wire or front loading may actually help increasing the trackability. Keep the sheath in proximity whenever deploying a stent, because one can always, when the sheath in proximity, the maneuverability becomes much better, and allow balloon to deflate, and whenever taking back the stent, and keep the surgeon handy. So I've just enumerated a few, and let's look at the few. So this is a 2-year-old child, post-op case of tetralogy, a transannular patch, a LPA plasty done at 4 months of age, a LPA stenosis with a definite indication, and the stent is, if you look at this is this angiogram which is showing the discrete LPA narrowing. The stent is, after the stent is nicely placed, this position looks good, and this everything looks perfect. Now at this point we are all happy, the stent looks nicely in position, the flow is good, and then comes the attempt to withdraw the balloon. But look what happens. This balloon has not been appropriately, a negative has not been done, and after balloon deflation the sheath should be carefully looked, and once it is withdrawn, the whole stent is embolized. Actually we needed to deploy it distally and deployed the another stent. Look at the another stent, a post-op case of tetralogy with a transannular patch and a LPA plasty done at 6 months of age. At 3 years, RPA stenosis, a definite indication. It's one of the old angiograms, and I've been doing it with my mentor, Dr. Radhakrishnan. And while we were doing it, the sheath is too far, and there you see, and as another stent is being placed, so we have already placed one stent, but as the sheath is placed, the stent has actually got embolized. So what next? What next? The stent has already got embolized. It was the distal end of the wire is nailed onto this. It has come into the RVOT, and with a careful extraction, since we are not able to redeploy it anywhere, this is being pulled into the sheath. Well, it was not a job which was actually easy. The wire was pulled across, and then a careful, slow withdrawal was done. We understand that is one of the most dangerous procedures, but with somebody like a senior mentor standing below you, the job became much more easier. Definitely, towards the end, everything looked smooth. Balloon stent combination. The message, the learning point is the balloon stent combination should be in proximity of the sheath, rather than the sheath lying much more far away. And rarely guarded snaring of the stent, as was done in this particular case, maybe a last bailout. Remember, this was not the first attempt. We tried deploying it at the other end, pulling it out, but the stent would always move constantly in the dilated right valve RVOT when it was snared across and brought out. This was another 60-year-old. This was another 60-year-old lady. Look at the CT scan. This is the proximal segment and this is the distal segment, and there is definitely a malalignment between the proximal and the distal segment, which are actually in a different plane. with an angle there. So this is a malaligned coarctation. We have been talking of malaligned interlateral septums, but probably a malaligned coarctation is an entity which we need to look at. Appropriately, a CP stent which was mounted 8 zig stent 20 into 45 millimeter balloon, because of this discrete narrowing as per the CT sizing was selected. Everything looked perfect by this view, but as the stent is being deployed, this is what we found. The stent has embolized proximally. Now, the proximal embolization of the stent means the stent needs to be redeployed either proximally or the patient goes it for surgery. Most of the reported case have reported either another stent deployment, which we can go across, or probably send it for surgery. So when in a problem, there is somebody who is going to help us out. And to help us out, there was this bioptome. Since our balloon had moved out and the snare was distant, we held what we were not able to intubate the stent with the balloon. We decided to take another bioptome to the same 14 French sheath, hold it with the bioptome, and what bioptome held was to stabilize the stent so that we could partially inflate the balloon. And once partially inflated, we brought the balloon back to the original segment and finally deployed, inflating the stent at the appropriate position, then inflating the proximal end of the stent so that it is flared up and well opposed to the aortic margins. And finally, this was the final angiogram showing it in appropriate position. So the concept of malalignment of the proximal and distal segments is equally important whenever planning a stent. It was a discrete coarc to begin with, and we thought it was an easy go with a single deployment. We fairly took a longer stent. 45 centimeters is a fairly long segment, considering that, yes, we realize that is a malalignment, it might just help, but still, probably, when deploying the stent, we saw only in a single view. The message we should actually see in at least 2 complementary views when deploying a stent, and probably bioptome could be an assist when remounting a stent in such bailout procedures. So peri-procedural complications, we talked of procedural complications. Now let's talk of peri-procedural complications, which include balloon rupture and stent migration. It can be avoided by a bib balloon with a serial dilatation of the inner and outer balloon, preventing excessive traction on the guide wire. Remember, whenever you are ballooning it, somebody should not push the guide wire down. It should be held. When it is pushed down, the guide wire tends to actually slip out. Of course, use of flexible stents such as a CP stent. The local complications, which is preclude use which is very important in small children. Carotid Doppler beyond 50 years of age with associated barrier aneurysm, which can get ruptured on the table in case the proximal pressures go very, very high. So one should be well aware of any distal aneurysm which is there, particularly when the patient is very old enough, more than 50 years of age, and of course, post-procedural complications. The follow-up include aneurysm, usually at stent edges, flaring of the stent margin after deployment, as was done in one of our case when we were in problem. We should keep a close follow-up. The incidence is just 4%, but we know these margins could actually impinge on the proximal segment and cause aneurysms. The neo-intimal proliferations is seen in 25% of the cases, and we know that this is one of the causes of stent getting narrowed, as was demonstrated in previous case, because it can lead to local stent complications. That there, one of the causes could be a neonatal proliferation. Effect on vascular compliance. Because of the rigid prosthesis, whenever there is a stent patient mismatch, there is always a possibility of hypertension persisting and the secondary complications. Tackling the aneurysmal lesion, I will go really fast. There you see aneurysm lesion, the wire is rolling out, and in such cases, probably a snare which could actually straighten off the whole segment, and we ended up deploying a stent. My videos were not well running, so actually I moved them faster. But because it was moving in the aneurysmal segment, we snared off the proximal segment and straightened it out so that we could deploy a stent. Restenosis rate. Well, restenosis in larger stent is pretty rare, but yes, is now common with so many patients being undergoing a stent implantations is highly dependent on the location, is particularly high in pulmonary artery stentings to the line of 25%. High is being in a subsets being tetralogies, with unifocalizations being done in multiple collaterals in Williams syndromes or Algili syndromes. Just to look at the restenosis, this was a case of severe pulmonary stenosis. We ballooned the RVOT, and there you see a discrete PDA, which was stented. We thought the things were easy. We stented the PDA, and within 24 hours, we realized the stent has actually, sorry, my video is here. So within 24 hours, we found the father was an angry bird, and the stent has, we didn't cover the proximal end of the stent. So it is important to cover whole of the length of the segment, deployed another segment and bailed it out. And in grown-up patients, well, this is a case of tricuspid atresia where LPA stenting was done and a full LPA was stented. Local trauma is one of the important complications. One should be looking at the local trauma in larger stent, as is demonstrated in this particular case. In the interest of time, I will jump the TAPVC stenting. I will talk of this endocarditis case, which is still awaiting surgery. In 2 days, he's going to get operated. He has got almost stented twice in another center, and there he presented with fever and endocarditis. And now, after 6 weeks of therapy, he's going to get the stent removed, and we are going to do an end run and repair. Well, stent local complications such as pseudoaneurysms are very, very important, as is being seen here. And the risk factor include particularly obese patients, females, hypertension, low punches, and multiple coagulations. Hematomas, which is a common complication, is much more seen with where large sheets are used, particularly in dissection flaps, whenever the larger sheets are used, such as in our case, in stenting cases. So it's always good to share the nightmares, and so that you can learn from others and think relaxing. Thank you.
Many congratulations.